Okay, while our next panel is making their way up, and I will be introducing our panel leader, our moderator, before I do that, I wanted to recognize two city council members who joined us later. That'd be Councilwoman Goldie Wells, I believe, is over there, and Councilwoman, I believe I saw Councilwoman Nancy Hoffman, if she's still with us. I think she had to leave. Okay, well, she did join us. Take my word for it, I saw her. Okay, our panelists are here, and I will introduce our moderator. Dr. Terry Akin is the Chief Executive Officer of Cone Health, a role he, Mr., all right. You're not, oh, okay. I gave you a promotion. You didn't even ask for it. Yeah. Is the Chief Executive Officer of Cone Health, a role he has held since 2014. Prior to joining Cone Health in 2009 as Chief Operating Officer, Terry held leadership positions at Harris Methodist Fort Worth Hospital, Presbyterian Hospital of Dallas, Cedars-Sinai Medical Center in L.A., and Washington Hospital Center in Washington, D.C. Terry's career in healthcare is driven by advice he received from his grandfather, a pastor, who told him, if you want your life to be about something, make your life about someone besides you. Under his leadership, Cone Health has achieved numerous national accolades, including Hospital Compare 5-star ratings for quality and top performer status nationally among next-generation accountable care organizations. There'll be a test on that one. Say that 5 times in a row. These awards reflect Terry's passion for healthcare quality and Cone's national leadership in keeping people healthier and saving substantial healthcare costs through value-based care. This model of care is focused on preventative care and working especially closely with people who are chronically ill to make sure they get the care they need when and where they need it. Akin earned an MBA from the Wharton School at the University of Pennsylvania. At the same time, he earned a Master of Social Work degree from Penn as well. While a student, Terry worked at Our Brother's Place, a shelter in Philadelphia, providing counseling and referrals for men experiencing homelessness. Terry has had a lifelong passion for service, community development, and finding financially sustainable solutions for persistent and systemic social issues. Terry is immediate past chair of the Greensboro Chamber of Commerce and past chair of the Guilford County Economic Development Alliance. In addition, he was a founding co-chair and now board member for the Ready for School, Ready for Life collaborative aimed at early childhood education and school preparedness. Terry is a fellow of the Academic College of Healthcare Executives and a recipient of their Regents Award for Leadership in 2017. He was also named to the Triad Business Journal's Most Admired CEO list in 2016. So help me welcome Terry.
Well, good afternoon. I appreciate that very generous introduction. Really gave me much more credit than I'm due. But in any event, just so wonderful to be with you today. And I always feel fortunate and blessed when I'm in the midst of a group of people who care as deeply as you all do, who care about deep core issues that really cut to the heart of the matter. So appreciate the honor of being here to play hopefully some small part in your program and in your learning and what you're taking away. What a wonderful opportunity to soak in all that Dr. Sandel shared with us. If you're like me, I mean, you know, my heart and mind are just completely stirred up and inspired, and so much to think about and assimilate. So thank you. Thank you for who you are. Thank you for all you do and for inspiring us. You know, Greensboro is really fortunate to have such a committed community of housing experts and advocates from all sectors, government, business, and nonprofits. At Cone Health, we're working really hard to be a good health care partner to all of you. We believe that our purpose is to connect healthcare and well-being. That no longer is healthcare about simply responding to people who are sick or responding to people who are injured, but actually partnering with people in the community to promote good health. And if we weren't serious about dealing with these core issues that you were here to talk about today, while trying to have an impact on the health status of our citizens, we'd be on a fool's errand. Never before when we talk about housing, when we talk about poverty, when we talk about education. You're talking about health by definition. They're inextricably linked. So I'm honored to serve as the moderator for our panel today. The panel gives us the opportunity to hear from some amazing leaders who are responsible for developing the sustainable funding and financial model that really will allow us to implement, sustain, and grow an integrated model of care. In this panel, we'll hear from Erika Ferguson and Andy McMahon, who are leading innovative approaches to fund the integration of social and medical needs. They have accountability for funding this work, as we refer to in healthcare as payers. Erika Ferguson is the Director of Healthy Opportunities at North Carolina Department of Health and Human Services. She leads the department's work to address the non-medical drivers of health, including housing, food, transportation, and interpersonal safety. Erika started her career managing a homeless shelter in the Mississippi Delta. Her experience also includes degrees from UNC, Duke, and Harvard. So you're ecumenical when it comes to the basketball.
Go Heels.
Go Heels, okay.
I thought you were going to be more conflicted.
We just needed to establish that. Andy McMahon is the Vice President of Health and Human Services Policy at UnitedHealthcare Community and State. UnitedHealthcare Community and State serves nearly 6.4 million Medicaid members in 26 states, plus Washington, D.C. Andy focuses on integrating and leveraging affordable housing and human services to provide better care at lower costs for populations with complex healthcare needs. His portfolio includes affordable and supportive housing, criminal justice, child welfare, and social impact investment. Erika and Andy, I believe that both of you are familiar with the U.S. DHHS Secretary Alex Azar's speech in November titled "The Root of the Problem, America's Social Determinants of Health." I'm sure you're familiar, most of us in this room are. I want to read you a quote from Secretary Azar's speech and ask you to be thinking about this. And also, if we have time at the end of the panel, we will open it up for questions. So be thinking about your questions as you hear from our speakers today. So Secretary Azar's speech, the quote from the Secretary's speech: "Social determinants of health is an abstract term, but for millions of Americans, it is a very tangible, frightening challenge. How can someone manage diabetes if they're constantly worrying about how they're going to afford their meals each week? How can a mother with an asthmatic son really improve his health if it's their living environment that's driving his condition? This can feel like a frustrating, almost fruitless position for a healthcare provider who understands what's driving the health conditions they're treating, who wants to help, but can't simply write a prescription for healthy meals, a new home, or clean air." So with that, we'll have our first question for today, and I will address this to either of our two panelists who would like to start. So many in healthcare are aware that we need to help with social needs to truly address health issues, but we may not know how or what to do. Erika and Andy, you too have definitely got some innovative ideas on what we can do in healthcare. Could you help us to understand what you're doing specifically to connect housing and health?
You go first.
Okay, I'll go first. First of all, good afternoon. Thank you all so much. Delighted to be here on behalf of UnitedHealthcare. We've been in the great state of North Carolina for some time, but are now honored and privileged to be able to partner with you all with the Medicaid population. So we're excited for that opportunity and responsibility, and appreciate really the amazing work that you all are doing here in Greensboro. Is really inspiring to me. So a thank you from me to begin. So the first thing I would say is Secretary Azars was right, and now the question is, how do we operationalize that, right? I think I've been in this space of integrating housing and healthcare going on 2 decades. And I am way too tired of talking about social determinants of health and came to UnitedHealthcare a year and a half ago to say, how are we going to operationalize that? What are we as a healthcare insurer going to do differently because we know the things that Megan said are true, right? So the question is kind of how are we going to actually operationalize that and not talk about it. So I'm going to give you all a brief overview, and then through other questions I think we'll be able to expound on a couple of them. But want to share with you all a 4-pronged approach that we've developed here at UnitedHealthcare in thinking about the role that we as a managed care organization can play in partnering with all of you all. And today's focus specifically on expanding housing opportunities, ensuring people stay stably housed, and those sorts of things. And I also want to acknowledge up front, I think the mayor said earlier, right, and she did not say it lightly, that there's a crisis, affordable housing crisis in Greensboro, and sadly you all are in great big company of communities all across the country in a similar place. So the challenge is significant, but I think we're up for it. And I also want to start off with saying that as a managed care organization, I think it was Megan who was saying, look, they're at BMC, they're not looking to be the builders of this or that. Neither are we. We're looking to figure out how can we play a good, strong partnership role with all of you all in the community. So to that end, I'm going to mention briefly the kind of 4-pronged approach that we are pursuing. So the first is around policy. And we were laughing over lunch that one of the big issues that we work on UnitedHealthcare is around kind of these tenancy supports waivers in Medicaid that we try to get from CMS. You guys have blown the doors off of all of that. You guys have done like tenancy supports on $500 million worth of steroids. So kudos to you all. I think that's an area that we're really focused on is where can we figure out that piece. But I think somebody earlier was also mentioning kind of where can we play roles with our housing partners, working with public housing agencies on administrative plans for how they allocate their vouchers. How can we play roles in advocacy at the state, local, and federal level? We quite honestly come to a conversation about appropriations for housing dollars from a very different place, right? We're not the housing advocate coming for more housing money or the developer coming for more units. We're coming for a different reason, and so I think we can play a really pivotal role, both in terms of the perspective that we bring, but also in many cases the analytics that we can bring that demonstrate the power of safe, decent, affordable housing and the impact that it can have. So the first prong is policy. The second prong I would say for us is around data analytics and clinical analytics. And so at UnitedHealthcare, we've developed a fairly robust, what we call kind of a hotspotting tool, which enables us to slice and dice healthcare claims and data literally in millions of different ways, but gives us a better way to kind of stratify the risk of our members, but much more importantly, then figure out what's the best intervention for them, right? For those who use the right kind of codes, which we don't have to get into in Medicaid, but if you're coded as somebody who's homeless, then we know that part of our intervention and support needs to be connecting you with safe, decent, affordable housing, connecting you with a housing navigator or something along those lines. So I think there's a lot that we're doing on the data and analytics side, and also trying to think about, and we certainly have a ways to go on this, but how we kind of embed housing into our overall clinical model. And I have fascinating conversations with our national clinical director, and she's very intrigued, and she wants to do it. It's kind of like, okay, well, how do we piece this together? So the second component is the kind of data and analytics and clinical work that we're doing. The third piece is around investments that we are making, and we kind of through UnitedHealth Group, which is the kind of large entity over UnitedHealthcare and Optum, to date have invested a little over $400 million in low-income housing tax credit projects, which we are very proud of. But quite candidly, we're also looking for ways to unleash capital that might be kind of latent in the marketplace, if you will. So it might be how could we better leverage 4% tax credits or other things or other vehicles that we might look to do. So I think there's some potential there around investments. And the last piece, and by far, exponentially by far, the most fourth critical component is around partnerships, right? And so, and how is that we partner with literally probably all the organizations in this room in various ways, but I'm thinking in particular how we partner with your state housing finance agency, how we work with community providers, how we partner with healthcare for the homeless, how we partner with your local continuum of care, how we partner with your local public housing agencies. And the list kind of goes on and on. So I would say, and this goes to Megan's point earlier, and we'll talk probably more later, but it's where do we find additional investment, but we've got to do a better job of aligning the investments we do make now. So I think I'll stop there for now, but that's kind of a quick overview of the four-pronged approach that we've put together around housing opportunities.
Thank you, Andy. Erika?
Sure. Sorry, I speak very softly and don't have a lapel, so I just want to make sure this is in the right spot. So, need to just dress better for these types of mics. So I know just one more piece of background around housing and how we're thinking about housing, and just like a little personal background. And I know we're either fast friends or not based on the basketball allegiance comment earlier, but just one more piece. I've been thinking about housing literally my whole life. I've had family history of homelessness, and I've worked in and thought in homelessness, different homelessness organizations my whole life until kind of managing a homeless shelter, and worked in very robust homeless shelters and places before, and this was definitely the different end of the spectrum, where going to churches every Sunday, multiple churches, trying to fundraise money to fix our shelter, and had very limited funding, and really trying to figure out how to do it. At the same time, I was taking it was 30 beds, clients to the hospital. It was pretty much the only place I took them besides needing help going to the grocery store and other places. I felt like we kept going to the emergency room. A lot of folks had issues with substance use or mental health conditions or other things, and I felt like I knew the folks down at our local ED more than anyone else in our very small community, and it just was really hard for me I didn't have a background in health or anything at the time, and didn't really understand this. I was just putting it together, and not to sound incredibly crass, but an advisor to me throughout my education always told me to kind of follow the money. I was like, I need to rethink this. This isn't working. And went to school for public health, and studied those pieces, and was so excited to come to the Department of Health and Human Services, where the Secretary's vision is truly buying health. And what it means to buy health is to look beyond just the four walls of the hospital and all of these other things that I was seeing in my personal life and career before, of housing, interpersonal violence, transportation, food, and how all of these things impact health, and how we as an agency, with our mandate of improving the health, safety, and well-being of all of North Carolinians, Medicaid and outside of Medicaid, how we need to do that better. And we have quite a large budget to do that, and we need to be thinking about how we align our funding, how we work with all of our partners, and do all of those things better. And that's a lot of the work of the Healthy Opportunities Strategy. So that was a little bit of a background, and not really answering your question. I promise I'll do a better job in future questions, but just to underline that, DHHS really wants all North Carolinians to have the opportunity for health, and we're doing that, or thinking about that, and creating kind of an innovative, whole person and well-coordinated system of care. And part of that, although that's much bigger than just the Healthy Opportunities work, we're pursuing kind of a comprehensive strategy around healthy opportunities. And that's really just the social determinants of health, I guess, where we are kind of struggling with the language. Folks in this room probably call it a lot of different things, non-medical drivers of health and others. we really call it the opportunity for health, and our shorthand is kind of healthy opportunities. So just caveat on that. So our folks might have seen kind of our 6-pronged strategy, and again, I think we'll elaborate more in the panel, but we created an interactive hotspot map of different social determinants of health indicators, similar to some of the maps shown that Megan showed in the presentation prior, which is really just used to show areas where we have large disparities in where a large percentage of our population is spending more than 30% of their income on rent, where we have food deserts, other things. So folks might have seen that map, and it's really been just used for planning purposes and advocacy, and really just trying to understand our community better. And we're trying to add over time more data as we have more data to really better understand our communities. And we've already seen really amazing changes from that map, where people have seen where some of their frontline workers are in kind of a crescent where it's of higher poverty, and increase the minimum wage there. There's a health system in our state who looked at that and saw an area where there's a food desert and is working with the community on building a grocery store there. So really exciting to see that come from the map, and how we can use that to drive change. We're also thinking about how really just asking the question in our healthcare system. I know Cone has been doing this for in a lot of this work already, really just asking the question and screening folks for their social need, and really understanding that as part of how they're thinking about that whole person health. So we worked with a technical advisory group to develop standardized screening questions for the state around that. Asking the question is important, but actually getting folks and navigating them to the resources is really the key of all of that. And there's a table in the back around NC Care 360. And I know that probably most of you in the room have heard about that at this point. Greensboro is part of the region that we are starting in, and that's a public-private partnership with the Foundation for Health Leadership and Innovation, with partners like Unite Us and 211 and United Way of North Carolina, to really create this infrastructure for uniting the healthcare system and social services, and being able to make these referrals and help folks navigate to the resources that they need. So I'll speak about that more, but that's really just an essential infrastructure to all of this. And then we've talked a lot about, we're working on some strategies around helping support the community health worker workforce, how to help connect people to benefits that they might already be enrolled in. We see that there are a lot of folks in Medicaid who are likely eligible for SNAP but not really receiving those benefits, how we can do a better job at streamlining those enrollments and things like that. And I think what's already been hinted at so far is a lot of our work, we're going through a Medicaid transformation. I don't think anyone in this room, most of you probably heard about that, or are a major part of that. So we're using that big transformation in how we deliver health in Medicaid to just embed a focus on these non-medical drivers of health into every single part of our program and our quality strategy, and how we deliver care management, et cetera. And then a part of that, and part of our waiver, I think this is what was hinted at, we received a lot of flexibility to create healthy opportunities pilots. And I'll talk a lot more about these, I think, later on. But this is just the chance to actually use Medicaid dollars to pay for some of these services we know are so impactful to health. So these are just some of the pieces. All of these things are across all 4 of our domains. All of them are a really big focus on housing as one of the 4 main domains that we're initially focusing on. So I'm really excited about how we can use Medicaid and the rest of our portfolio to really support the housing work in a different way.
Great. Erika, thank you. And Erika, thank you for sharing so generously about yourself and your own background. That has a real impact, it really does. Andy, I want to address this question to you, if I may. So your work in 26 states gives you the opportunity to compare a lot of different initiatives, I'm sure, and programs. And as with many of us who are trying to, bring transformation, oftentimes we have to kind of fail our way to success. And so I'm sure you've seen some false starts. I'm sure you've also seen some superstars. Interested in hearing your perspective on some of the common elements that you see when we have success on projects, and then maybe conversely, what are some of the barriers, what are some of the breakdowns that occur and those that don't work out so well?
Sure. Thank you. And before I do, I was remiss in saying that even though I know I'm speaking to a divided house, I need to say that I grew up in Maryland and live in Minnesota, but I'm a die-hard Carolina fan. I'm 48 years old, and I loved North Carolina since 1981-82 with Michael Jordan. And my kids are now 12 and 14, and they think I'm a bandwagon fan. And I'm like, I've been at this almost 4 decades, you guys. So I need to own my own bias.
And I'm from Texas. I do not have a dog in the fight. So.
So you're right. I think we've had successes and challenges. So let me mention a key success and then a challenge, and then kind of try to wrap up where I think some of those key elements are, and probably where some of those weren't aligned or weren't there when we were doing it. So to start with the good news, I think one significant success we've had is that we have a national initiative going on with the Robert Johnson Foundation and the Council of Large Public Housing Agencies, or CLAFA as they're affectionately known in Washington, D.C. They are an association of all the large public housing agencies in the country. We have developed formal partnership agreements and MOUs, as well as data sharing agreements with 6 PHAs in 3 states. In Ohio, with the Columbus and Akron Housing Authorities. In Texas, with the Houston and Austin Housing Authorities. And in Washington, with the King County and Seattle Housing Authorities. And also through the data matching and agreements that we were able to do, I've worked with our healthcare economics team and just issued our first reports last week. But we're able actually now, amazingly, but for the first time, to understand the overlap of our Medicaid membership with individuals in publicly assisted housing. So to take the Seattle-King County area as an example, it turns out we have, and this is absolutely the lowest possible number, we have more than 12,000 UnitedHealthcare Medicaid members who are living in King County, Seattle assisted public housing, right? So that's 12,000 individuals for whom we are responsible for their health care, and we want to improve their health outcomes, and they're responsible for making sure that they have a safe, decent place to live. And until about a year ago, we had never talked to each other, right? So that's crazy. Wow. So what we do know now, though, is that we're able to we just shared with all the public housing agencies last week kind of a whole reams of data of understanding the level of serious mental illness in their communities, understanding the level of very high acuity needs. And one of the things that I would share with you guys is that, not surprisingly, but in publicly assisted housing, there's a huge percentage of people who are very, very ill. And I can quantify that for you, though. So now what I can tell you is that across all of those PHAs, somewhere in the neighborhood of 32%, I work with healthcare economists, so I say the neighborhood of 32%. Somewhere in the neighborhood of 32% of those members that we identified have more than 10 risk factors related to their health. And so, the way to think of it is if you have 0 to 5, you're pretty healthy, relatively healthy. If you're 6 to 10, you probably got a few bangs and bruises, but you're okay. Once you get into the 10, and we have tons of people who are 20 or 30 risk factors, you're talking about a high acuity of need. So the important thing, though, isn't doing those data analytics. The important thing is now what we're going to do about that, right? What I would call the insights that we're going to garner from that data. And what we're going to do then is to say, okay, what are the population health types of things that we ought to be doing with King County Housing Authority? Should we be doing diabetes management classes? Should we be doing any number of things we could do? Should we be having community health workers, our employees, at different public housing, public assisted housing developments 3 days a week, because we have a whole slew of members there, and increase their access to care and the better coordination of their care. So I think, and we literally are just at the tip of the iceberg on that. We literally did the first data poll last week, and so just in talking to them last week, there's enormous amount of interest and insight, and then how do we work together, right? We have all these folks, and I think as Megan pointed out earlier, there's certainly a substantial number. I think they found around 50 in Boston. I've seen actually just only 25% in Seattle-King County of their highest utilizers are homeless. So that means a whole slew of them are living somewhere, right? And a lot of them are living in publicly assisted housing. And so that's what we're trying to address from a very analytic perspective. I mentioned analytics earlier, and partnerships. So I should have said too, I have a simple brain, so I needed to give you guys kind of like a 4-pronged approach. it actually goes like this, right? And then in some sort of convoluted way is how those things work. So that's on the plus side. I would say we've had a couple of initiatives, what I would call kind of non-starters, if you will. And I would say that a couple of the key issues were related to capacity on our end and on potential partners' end, right? And so like in our health plans, I think we have all very, very strong, good health plans, but not all of them are well positioned and have the resources and things that they can dedicate to these specific types of things. And so it takes, in order to do these partnerships, right, like everyone has to not only want to do it, but they have to have the commitment to it and the resources and the expertise and the capacity to do it. And I say that, let me be clear, from a provider perspective, also from a UnitedHealthcare perspective, we have to come ready. And the way the story I tell about this is that my wife has made me and our 2 children go camping like 4 times in our lives. Like she wants us to be a camping family because it's nice. We're not a camping family. So that's what I would say. Like, so you can't just want to have the partnership, right? It can't be like, geez, wouldn't it be nice if the hospital partnered with the housing developer? Sure, it'd be nice, but are you committed to doing it? Do you have the resources to do it? Are you oriented to do it? And so making sure you have those things in place, I think, are key. When I think about kind of what are those key indicators, what makes things work or not work, I would mention a few things. So one is absolutely the data piece, right, in terms of understanding shared populations is so key to the cross-sector work. I can tell you in my past life, very quick story where I was working with the head of Health and Human Services in New York City and the head of corrections in New York City, and they were both screaming at each other saying, oh, you dump all your people out of your jail and onto the streets of New York. And the guy looks at her and laughs and says, are you kidding me? Half of those people are in my jail because they sweep them up off of the streets. Yep. So they were pointing the finger like this. We actually did a data match and found a huge shared population between New York shelter system and Rikers Island in New York City. Voila, we showed the data. We saw the shared value in working together. And we created huge, powerful partnerships in New York that we've done elsewhere. So I think that data piece is really key. I think then the outcomes component of that, of understanding kind of why are we doing this work, right? Sometimes you need to certainly be able to take the long view, right? Sometimes our horizon is further out than we wish. So I think those are some of the key elements from our perspective.
Great insights. Thank you, Andy. So Erika, you and your team at North Carolina DHHS are really breaking new ground in our state and nationally with your work on Medicaid transformation. Why would you say that North Carolina has chosen to move so boldly on integrating social needs into healthcare?
Sure, I think I touched on this a little before, and in that, I mean, it's our mission to improve the health, safety, and well-being of all North Carolinians. So all of this work, with the exception of what specifically in our waiver is thought to be across the entire population, and really creating that infrastructure that the state should provide to really allow folks at the community level to do the work that they've already been doing and be even more successful. And we saw this. We started this work in 2017. In the summer of 2017, we had about 80. We knew we wanted to do something in terms of buying health and what that means, and we're still trying to tackle that and figuring out our language and still figuring out our language, all of those things. Summer of 2017, we had all of these stakeholder conversations, and one thing we heard over and over again was just folks asking for, they're doing all this work, they're way ahead of us in understanding how to do the work within their communities, but the state needs to provide kind of the infrastructure to do that better, and how we think about how do we unite the healthcare system and the community-based organizations or the human service organizations, and what's like a shared, how do we share data and information and things. And I think that's a lot of what NC Care 360 is trying to solve, and really allowing for kind of that data exchange and working together in kind of a new way, or a way that wasn't formalized, I guess, or so that's a lot of what NC Care 360 is doing. And then the other piece is really just how do we embed our work, the community and social service side, into healthcare delivery. I think that's a lot of what we're trying to really learn from the pilots. I'm doing it again and not answering your question directly.
You're doing great.
But wanted to just share that point. I think from talking to other states and to what you were just talking about, a lot of that infrastructure is missing, and we're really lucky that we are late in the game and moving to managed care. And so we have a lot of, we can learn from the successes and errors of other states and how they made this transition and how they work to tackle non-medical drivers of health within their systems. So when we can see that some of the infrastructure, that underlying statewide core infrastructure, that not being built early and initially at the same time, kind of it paralyzes them from taking the next step and moving the needle. So excited to build things like NC Care 360 and be starting on these pilots so early in our work. I think we're also a super agency, so we do a lot more than just Medicaid. We have health and human services. So it's really our mission to really combine and knit together, and we're thinking about how internally we do that better. I mentioned quickly the cross-enrollment, but how we just get our data systems to talk to each other across all of those different divisions, public health and mental health and Medicaid and social services. And I mean, boy, our data strategy work is a lot right now, but we really need to work on all of those things and really unite it within our own department. So we're really walking the walk and really uniting healthcare and social services, which is so key. And I think also why this is so important beyond it's our mission. I mean, that's core, and it's the right thing. It's the moral right thing to do, and there's the business model for it, which we'll talk about ongoing, of how all of the slides that showed all of the cost savings that we could potentially see and all the improved health outcomes. I think one other point to make, or how our healthcare payment system is changing, is our shift as we shift to value-based payment and are giving providers and health plans more flexibility in how they improve health, giving them all of these infrastructure pieces and all of the NC Care 360 data and these pilot delivery systems and how we create these hub and spokes models and all these things we talked about are really important infrastructure to even think about getting to value-based payment in a real way. So I think that's just another piece of all of this and how we are changing kind of healthcare delivery. So I kind of took a turn around, but.
No, that's great. And I'm struck listening to the conversation by how often, almost without fail, the right thing to do, elegantly, almost always turns out to be the most cost-effective thing to do. And makes the most sense from a business and economic development standpoint, and that works for us for sure. Andy, speaking of bold, what are you and UnitedHealthcare looking for in a Healthy Homes program and a practitioner community? What would make you, as a health insurer, actually want to invest?
Sure, excellent question. So I think. A few things, and I think in a different level, I'm going to say data again, and that is kind of the analytics of like demonstrating the efficacy and the impact and the outcomes that are achieved. I think is probably first and foremost. And let me be clear, I think it can be a combination of metrics, right? It isn't always just like, oh, okay, well, did this reduce costs or did this not? Did it increase access? Did it increase quality of care? Did it increase health outcomes? Or there's a whole host of things that we track ourselves and that our regulators look to us for that are not just about money. So I think I want to be really clear that there's certainly a piece of it that is the extent to which you're coming to saying, okay, well, we've got this and it's going to reduce these costs by X. That's compelling. But that isn't the only thing by far that is compelling. So I think that is definitely something we are looking at. I think over lunch we were laughing about working with actuaries and healthcare economists. And And it's real, right? So we're lucky at United, quite honest, I say this very genuinely. We have a remarkably group of creative actuaries that I get the pleasure to work with. So we can kind of go back and forth. Well, I can say, well, hold on. Well, how about, could we think about it, maybe slightly differently than you're thinking about it? So I think, so I think there's some creativity there. And at the same point, it is also math too, to some extent as well. But so I think that piece is critical. I think the capacity, demonstrating the capacity and expertise to execute, I can't understate, right? And that isn't always, let me be clear, that isn't always, oh yeah, we've been here 50 years. In some cases, you've been here 50 years, you've done a great job, and you have a great reputation. It's a feather in your cap, good for you, and that helps. But I also don't want to just say that, oh, if you haven't done this for 30 years, that that we're not interested in partnering with you. That's why I think of it more as capacity and expertise and capability, right? But I do think, I will say that is critically important for us. I can tell you, in thinking both on thinking about some of our work in our network and providers, and also I do a decent amount of work on our impact investing with our UnitedHealth Group Treasury team. I can tell you, they ask very few questions about the finances. What they ask is, Andy, tell me about the partner you're bringing to me, what they're going to do, and what the impact you're going to have, right? So I think that notion of an entity that is going to execute, and that we have there's some veracity in the data, and we have the confidence level that you're going to use. So I think I'm happy to say other stuff later, but I'll stop. I mean, I think really those are the key issues.
Great, thank you.
That intrigue us and give us confidence that it's a partnership that we're interested in doing. And just to reemphasize that the finances are important, but there's a whole set of metrics that we track and are accountable for. So.
And again, having the right impact, the finances tend to follow.
Yep.
So, great.
Exactly.
So Erika, can you tell us about the Healthy Opportunities Medicaid pilot program, and maybe a little bit closer to home here? How have you designed this initiative, and what are the opportunities for a community like ours here in Greensboro?
Sure. Sorry, I was looking through my notes quickly. I took 100 different notes that are scrawled all over this paper from all of the other talks that we listened to today.
In very small print.
Yeah. So I have
Don't look
no
at
idea
mine.
what any of it says anymore, because I was just copying down all the very insightful things that others were saying throughout the day, particularly the comment and thinking about the Healthy Opportunities pilots. I think this comment or this thought is really key. I think that Josie said earlier is that you can't tell me something can't be done. And I think that the pilots are really kind of an exercise in thinking about that, because we are really trying to think about how to really change and embed delivering these non-medical drivers of health, these evidence-based interventions that we know improve health outcomes and drive down healthcare costs into our healthcare delivery system. And so today we have a healthcare system that oftentimes asking somebody, are you hungry, or do you have a safe place to sleep tonight, or is so outside the realm of what counts as healthcare, that in North Carolina we have some of the best health systems in the country, but how do we deliver health if even if folks get the right diagnosis, have insurance, have transportation to the pharmacy, all of these perfect factors coming together, if they don't have the funds, the ability to pay their electric bill, the ability to refrigerate their medicine, they can't, it doesn't matter. And just on that note, off topic, we do have extra funds. I will be remiss to say, and now I'm going off topic, we do have additional LIHEAP funds in the state. We still have $11 million. So if you are touching people directly, or the ability to get out that funds, that the state does have additional LIHEAP dollars, which does pay for things like heating bills for families. We do have $11 million, and that's all federal funds that we don't want to send back. We want to get to the people who we know need them. So I'm just going to remiss in not saying that and making that plug to send people to their DSS office. Thank you. Sorry, I'm getting a little off topic. But that's all so important, and it's so important to health. And we will pay. We're right now the payer, as we haven't transitioned to managed care, and even still, we'll still be the ultimate payer. We're paying for the readmissions bill, which is a lot more expensive than finding a way to pay for that electric bill. And there are a lot of other examples of folks share today of the same sort of story. So we through our Medicaid bill, or through our 1115 waiver, Medicaid bill, our 1115 waiver, we're the first state to receive such a huge amount of flexibility and the ability to spend Medicaid dollars on the evidence-based interventions that we know are directly impacting health. And these are across our 4 domains, housing being one, and it really allows us to pay for so much of the tenancy supports, as well as home modifications and repairs, as well as things even, and I know everyone in this room knows it's not enough, but things like first month's rent and security deposits and up to 6 months rent after readmissions, which is huge. So we received up to $650 million of Medicaid dollars to actually pay for these types of services, and how we're envisioning that going. And we've put out, I think there are slides and things here. I've seen them around. So I think a lot of the folks in this room have already been thinking about these pilots for a long time. So forgive me if I'm saying things you already are aware of. But the pilots, we're thinking about how we're really trying to figure out how to embed this within our system that we're already building. So it's truly embedded into how we're delivering Medicaid through managed care. So the money will go through the health plans. And through their care managers. The care managers will be the ones working with folks to understand if they're eligible for the pilot at all, meaning they have at least a health need and a social need, and then what type of intervention they might require. They will work with a lead pilot entity, which is really creating a network of community-based organizations and social service agencies in the community. They're kind of the hub, and with all of these different providers as the spokes, working with the care managers to direct people in the right way. And then the funding will flow so that we're actually paying those human service organizations, those CBOs, to deliver the services to these folks, actually delivering a medically tailored food box or first month's rent or landlord engagement or tenancy supports. You have it, whatever is on that list. So we're really trying to embed all of that into the structure with immense amount of evaluation to really prove all this data, prove that it's working, CMS is looking,
Yes,
as well as our state, making sure that we're being great stewards of resources and really to improve health and drive down healthcare costs. I do want to make one more point about the pilots. We talked a lot about high utilizers and focus on that's where we're going to see. There's 100 studies around someone with a number of chronic diseases and experiencing homelessness, and if you house them, all of the cost savings you might see. There's also a point about moving upstream, and that those kids will eventually be your high utilizers. So just want to make that note that we are a large amount of our pilots is making sure that we are getting to those kids and getting upstream as soon as. And especially since Medicaid is mostly kids in North Carolina, so that's a big component of our pilots as well.
Great, thank you. Well, I have one final question, and then we'll open it up to questions from the group. In the face of profound challenge, I'm guilty of being an optimist, and it's just kind of how I'm built. I believe in people. I believe in humanity. In that vein, I'm going to ask this question to both of you. What inspires you most about this current moment in healthcare? What advice do you have for us in Greensboro about how we can build on our successes and take advantage of this important moment?
So I'll halfway start. I think I could get my phone out and take a picture of this room and tell you that's why. Quite honestly, is what I would tell you. So kudos to all of you all. I think from where I sit, I think that it is there's a whole set of things that are around the resources and the systems, and we talk about all these things that are not human objects, right? That are our barriers or are this or that or that. All of those things are controlled by individuals. They're controlled by people, and so I think that The most inspiring part to me, in particular here in Greensboro, is the talent and the commitment of the people in this room. Honestly, I think, and I will say, so I'm an optimist also, but I can tell you too, one of the things that I would say also in the many lives I've had over the years in thinking about kind of vetting ideas, and you're saying, okay, and I've actually had the good fortune of talking to a number of venture capitalists in some of my lives, and one of the key things that I would say, like, there's like, everyone comes pitching these ideas, right? Like, what's your idea? Well, we're going to do housing and healthcare, and we're going to do this and that, and here's our contraption. And if you talk to most of them, if you get a chance to talk to them, it's fascinating. They will tell you it is the individuals that they bet on. They don't bet on concepts. They bet on people. You know, and so what I would say is I'm betting on you all and look forward to staying involved. So thank you.
Very powerful, very inspiring. Thank you. Erika.
I would just reiterate the same thing. I think we're at an important time in our state, in that I think from my perspective, the Secretary has made addressing these non-medical drivers of health and housing as a top priority of our department, which is just really inspiring every day to work in that kind of environment where all of these divisions are working together to solve healthcare as housing, essentially. So that's huge. I think we're seeing a lot of payer alignment as we're all moving toward Medicare has kind of been pushing this forward, and now I think as we move to managed care in North Carolina, Medicaid, and then their commercial populations are all shifting toward value and really allowing that flexibility and that push toward addressing all of the components of making someone's health. And this new payer alignment really allows providers and health systems to really expand on what you already, frankly, have been doing for a long time, and really have that flexibility to truly address the whole person's health, which is just really exciting from a payer perspective. But I think all of this is really about community organizing. I think that was said earlier, and I've been now in Greensboro. I think I've been to in the past 2 weeks. I've been here like a number of times to really, and I just get more and more inspired, and every time that I've come here to visit with folks, and just to work across county lines. And we know in North Carolina it's kind of hard. We are so county focused. And just the ability to get all these people in the room to talk about healthcare and housing, and we are so past the conversation of, is this important, and just how do we implement it, and how do we go, and how do we go faster, which is just really inspiring to be a part of and a partner on.
Great. Thank you for sharing that inspiration. So let's open it up to questions from the group. Yes, Sharon.
I'm going to start. I'm sure it's going to go downhill. I appreciate both of you being here, and I appreciate both of you talking about the things that are important to us. But I want to go to you, Erika, because you said something just a few minutes ago, and I turned to Brett, and I went, what? Now, as a resident of a state who has refused to expand Medicaid, because that, until they do that, we really can't help folk, okay? Because we've got 500,000 people that need it today and that are dying. Every day there are people dying because they cannot get health care, okay? And so we can talk about that at some point, and we could go on.
We should talk about that now.
Well,
we should talk about that all the time.
Yeah, I mean, that's a every day, every minute, every second subject. We've asked our state to expand Medicaid. We're asking them again. We support it here locally because we know the impact that it will have in the community that I represent. I represent 68% African Americans. I have the district with the most poverty and the lowest of income. Okay. But as an elected official, every day I get a phone call from somebody who needs their lights on. And to hear you say that DHS has $11 million, who's holding the purse string? Because I'm telling you, it is not open here. Brett gets it because I call him daily and say, or his assistants say, I got somebody on my phone who needs some help with their utilities, they need their lights back on, their kids need to go to school, all that happens. But they're on the phone crying to me because they said, I've been everywhere. Nobody has anything. It's troubling to hear $11 million that's available, but it's not accessible. There's a difference between the two.
Yes. I think, so I can answer that in two parts. So for I think we, across the board, we could do a better job at this communicating, and there's definitely a work on proactive communication and transparency and how we're just across all of our programs and all of our books of business. LIHEAP is a program that is administered at the county. It's federal funds that go to the county level. So folks would get that through their division. They would go to their local DSS office to access those funds. I'm happy to send more information to get that information out to all folks who touch people who can get that information out further. We run a lot of other programs that do that, and other sister agencies run similar programs around housing, and just making sure that all that information about resources is accessible. I think that's part of the goal of NC Care 360 and trying to connect folks to resources. I think that's part of the role of kind of how we're thinking about a lead pilot entity who would really be the hub that would know of all of the community resources and things like that. So those are some kind of solutions that we're building within our broader work. But to your point, I think that's so important. And want to also reiterate the fact that when 500+ thousand people in our state don't have access to health care, it's hard to talk about creating a healthier North Carolina without that. And I think that's so important. I think there's work going on at the General Assembly right now on moving that forward, and hopefully we get there. But I can't. I'm happy to hear you say that, and can't hear that and say that enough about the role that Medicaid expansion could play in North Carolina.
I'll just editorialize. I think it's one of the biggest tragedies of our times that we have not expanded Medicaid. And we could spend a long time talking about, there's a lot of work going on, including with Secretary Cohen and others, to really try and partner with our General Assembly to navigate some very, as you know, some very complicated political waters. But it's absolutely the right thing to do. And people are suffering because we haven't. Yes, over here. Oh, okay. How about here and then here? Yes.
I wanted to kind of piggyback off that. I went to the NC 360 intro, and there is going to be a time period. So in the meantime, a resource that we do have in our area is 211. And that's what we're all telling people to call. When they call us by mistake, our agency, we have to refer them back to 211. So why does 211 not have this info? Because they're telling people to call us because they're out of resources. We don't do this in our agency, and so people are getting frustrated. They're getting sent around to different agencies, and we are not meeting the needs of our people, when all it would take is in the interim until this NC 360 is up and running and we're all really connected, that someone let 211 know to better direct these people.
Yeah, yes. I would agree with that. 211 is a part of NC Care 360 as well, so in the ongoing, that call center is still going to be a major part of directing folks to resources and making sure that they are acting as kind of a care coordination, and this coordination to resources and navigation at scale is really important, and making sure that they have the information is key. And if it's about the LIHEAP specifically, I think we do have a way of getting that information. I think we could do a better job across the board. Sorry. Yeah.
For those who don't know, what is LIHEAP?
Sorry, it's this is a low income heating and energy assistance program. Yeah, is LIHEAP. So I didn't mean to derail the conversation, but that is one example of getting that information out, that we have funding remaining. We put out a press release, I think, a couple days ago to let partners know about it. I mean, that's not the best. We have put out other communications about making people make sure that we don't want to send funds back that we know people need and other resources.
Over here.
My question is with the funding through DSS, the process is very long, and it's frustrating for some of the clients we have to take to DSS to apply for these emergency assistance. Is there any way that process could be less frustrating? I don't know. State, maybe.
I think that could be said about a lot of the programs that we administer. I think we're trying to do a better job in looking at our data and others and our data strategy about how we can do more at the department level. And this is just our department, about how we can do more about streamlining enrollment into a lot of the programs, and think people who might be likely eligible for one program because they're enrolled in another program, how do we either communicate proactively and or really streamline enrollment. So I think we're doing a lot of work around that now. We're trying to make our e-pass and other things more user friendly. So we're trying to do a lot of that work now. It's a data lift and a technology lift, but both of those are so important to actually getting people into the resources that they need.
And I would just say from our perspective at UnitedHealthcare and our partnership with these guys, that I think we're doing a lot of work that's looking at kind of how do we improve and our screening for various social determinants and do other things. So I think clearly I have no doubt there are areas for improvement for you guys. We have plenty of our own areas for improvement, but I guess I just wanted to say that from our perspective, partnering with the state, so you come in on managed care, there's been a lot of focus and interest and commitment around some of that screening and then referral, right? So how do you, because I think your point is well taken about the access stuff, but so how do we create a better kind of screening, referral, and kind of connection to both healthcare but also these other services? So clearly things to improve upon, but I think at least in our work with the state, there's been I think a lot of commitments and focus to doing, actually I would say in the years ahead, making leaps and bounds in that area.
Absolutely. So, ladies and gentlemen, this is one of those hour-long panels. It could easily be a 3-hour-long panel, and we are at our time limit. Let's acknowledge and thank our panelists very much.
Thank you.
Lots of challenges ahead, but kind of like was said here, visiting with these two panelists, seeing and feeling and hearing the deep commitment that's in this room gives me great encouragement and confidence. And so thank you all very much. All the best for a good rest of your day. Thank you.
Okay, to wrap things up, I'd like to welcome Derek Ellington to the stage. He is the current chair. So Terry was the past chair of the Greensboro Chamber of Commerce. Derek's the current chair, and he is the the president for Bank of America here in the Triad.
Good evening. I think we all owe a big round of applause to all these great speakers we've already heard today. Super engaging. Thank you to the folks that helped pull all this together, because I'm a believer that great things don't just happen. A lot of people make them happen. So one more big hand for our leadership. Thank you so much, and your vision. And I'd just like to start by saying that today, you're probably saying, why is a banker here? And I'm going to dispel that myth for you by the end of this presentation as to why I'm here, because today I'm uniquely positioned in this discussion, and it's led to some terrific collaborative activities in the Triad that I believe are moving the dial, and they're continuing on this path that we've been talking about today. And I'd like to say a few words about why I'm here. I'm here today as an advocate. I'm here as a funder. I'm here as a convener. I'm here as a thought leader. I'm here as an educator as it relates to financial literacy. And I'm here as a catalyst for change. And I think when you take a step back and you look around this room, it's amazing that all those components are in this room and taking action on being a part of the solution here in the Triad. As a financial institution, you know, we are uniquely positioned on all spectrums as it relates to all the folks that are impacted, both by affordable housing and access to affordable housing, as well as on the healthcare spectrum. We're leading the way in financial literacy and making sure that folks have the information they need to be both homeowners and in some cases renters. And I say both because in today's economy, renting might be the best option depending on where that person is in their life and in their lifestyle. So having the financial literacy to stay in your apartment or the home that you're renting is critically important. And we play a leadership role in that. Also providing access to financial solutions on the ownership side that help folks that may be low to moderate income gain access to a mortgage that is specifically designed to help increase access in those segments of our economy, and also supporting financing those developers that are building low to moderate income housing as well as apartments in the space, and helping facilitate programs in partnership, in some cases like with the city of Greensboro and others, where the city may take an equity position in the project that may be forgivable at some point once the project has met certain criteria. And from a financial institution, that reduces our risk associated with the project. And on the developer side, it brings their costs down on the financing in such a way that they're able to charge lower rents and ensure that the process has a better chance, the project has a better chance of being successful. So again, those partnerships, those opportunities to think about strategies and structures that can accelerate closing the gap around the access to low to moderate and affordable housing in our communities. We're not just a lender and a leader in financial literacy. We also are a leader on the healthcare side. We provide a lot of financial support to all the healthcare institutions in the ecosystem. We work with a lot of them throughout their cycles when they're thinking about the strategy and how they deliver a lot of their capabilities to their patients. We work with medical device companies that may be developing artificial knees, artificial hips, pharma companies that are developing drugs that are addressing chronic diseases that partner with us for financing during those early stage development processes where they're testing a lot of those drugs that have not yet gone through that FDA approval process. Very involved in those components, as well as the biotech companies that may be doing research around chronic or critical diseases that we have not yet found cures for. And we're a major funder, particularly to those nonprofit housing entities like all the members of our Greensboro Housing Hub. Would those members please stand? The members of the Greensboro Housing Hub. Let's give them a big round of applause here. So if you were listening, I said every one of the members of the Greensboro Housing Hub we funded individually. Every one of them. And this Greensboro Housing Hub is not just a model for Greensboro, it's a model for our state of how collaboration can really come together in a unique way to where you create a one-stop shop, no matter where people are on the spectrum of a housing need. And it was so important that our governor came to Greensboro for the opening. And again, it's the model for the country in what we're doing. And I want to talk specifically about Habitat, who's in that hub. And Habitat is one organization we funded not only locally but nationally as an institution. And we talk a lot about helping people gain access to housing, which Habitat does a tremendous job in our community, addressing a need in our community, providing financial literacy to those folks who are trying to get into a home. And we've partnered very closely with them, not just on the front end of trying to, build the homes get people in the homes. But then on the back end, another critical area that many people may not know about, that came out of a lunch that Maria and Hanlon and I had, that was, we were brainstorming about how to improve the partnership and how to create more impact in the community. And we began to talk about the 15 to 20 homeowners every year that are Habitat homeowners who have worked hard, saved money, in some cases taken their spare change and made additional payments on their mortgages to pay them off early, and we've provided additional funding to Habitat to celebrate those mortgage burnings and mortgage shreddings. 15 to 20 a year in Greensboro. So again, it's not just getting people in the homes, but providing the financial literacy support throughout the process, giving them training on how to maintain those homes, so that it becomes a long-term asset that they can transfer to their children or do whatever they decide to do in their life to reach their goals and their dreams. So again, those partnerships are really important. We're also a major community leader of action. Personally, you heard mentioned, I've personally served on the Greensboro Chamber Board as well as East Greensboro Now's board. And both of those organizations are focused on creating more affordable and healthy housing in Greensboro. And we know if we don't do that, we can't attract new employers, and we can't retain existing employees or attract new employees to our community. Healthy, affordable housing is a key component of economic development. And both of those organizations really clearly understand that and have programs in place to try and improve that access in our community. We're conveners and catalysts for healthy change. In the last 6 months, we created a local healthcare think tank. And again, that question was asked, why is a banker doing this, creating a healthcare think tank? And our very own Terry Akin, Anita Bachman from UnitedHealthcare, many others in this room, we have all the major healthcare providers as a part of the think tank leadership. We have all of our research institutions on the educational side as a part of the think tank. We have many nonprofit leaders. We have several large leaders of large religious organizations who are focused on health disparities within their congregation. And for the first time, when we brought this group together, the banker leading it, the competition didn't get in the way. The competitive nature of protecting my individual silo didn't get in the way. We talked about the common issues that all of the institutions are trying to solve for as it relates to health equity in the triad. And the conversations have been rich. We've started to formulate areas of focus as a unified group around finding solutions to create, again, greater health equity here in the triad for everyone, particularly those most at risk, those zip codes with the highest poverty levels, those zip codes with the greatest food insecurity, and other determinants that we've identified that are critical to our success. But again, everybody's at the table. We got everybody's taking off their competitive hats, and we're thinking about how to solve for some of these issues that continue to be chronic in our community. We also made sure that in that conversation that, health equity includes access to affordable and safe housing. So again, all these things are linked together. We've heard a lot today from all the presenters, and I'm confident that when we look around this room, we've got the right people involved, we have the right resources, we've got commitment from everybody that's in this room. It's been very clear, that commitment. So the one piece is just continuing to strengthen the collaboration. Strengthen the collaboration at your tables, strengthen the collaboration around this room so that we can begin to affect change. And I heard from one of the other speakers something that I thought was a perfect acronym for this Greensboro group assembled today. And that acronym was BUILD. And I think that acronym BUILD is something we can all take away, and as we become ambassadors, as we go out of this room, we should be sharing that, BUILD, with all the folks that we touch in this community as a convening word to get everybody focused on the change that we're going to affect. And let's repeat what BUILD stands for together in this room. So first, the B is bold. Okay, the U is upstream. The I is integrated. L is local. And D is very critically important, data-driven. So let's do that. Let's go out. Let's be ambassadors in this community. You've heard everything that you need today. You've seen the support around this room for changing our community and continuing to create a place where there's affordable and healthy housing for everyone. Let's work hard together to be part of that solution. Thank you.
Very quickly, how long do I have? I'm just joking anyway. It's been a very long, productive, informative day. I always say that you can judge the success of an event by how many people are still there at the end. If you look around, this room is still full. And on top of it, the people in this room are all change agents and all can't sit still. And I say that as somebody that cannot sit still. So give yourselves a hand for sticking in there and being here all day. Thank you, Ms. Carolyn Biggerstaff, for your tireless advocacy on behalf of housing in the city of Greensboro. Thank you, Brett, for your leadership, and you have been great. And all of the staff of the Greensboro Housing Coalition, give yourselves a hand for pulling off this great event. So this has kind of become an annual thing. I think I've been here every year. I've missed maybe one or two since the bus tours. So we will make sure that I'll be back next year. Brett is holding me up, giving me a sign. Please take home the centerpieces that are on your table. And with that, thank you, City of Greensboro. Thank you, everyone. See you next year.